our fifth echo session on HIV and aging. So for those of you who are new to the program, welcome. I'm Pui Lee, an infectious disease physician from University Malaya in Malaysia, and I'll be facilitating today's session. We typically have our hub members, and I think throughout this hour, they'll all be joining us. We have Dr. Kajal and Dr. Wirasak, our geriatricians. We'll have Dr. Grace and Dr. Jennifer, our ID physicians. Dr. Ken and Dr. Hazana, our primary care physicians. Dr. Julia and Mr. Kenneth, our rehab medicine physicians and physiotherapists. Our psychologist, Mr. Han Yang and Dr. Barry, our nurse, Sister Cheng Hong, and our pharmacist, Miss Pretty. So welcome to everyone. For those of you who have missed our previous sessions and are interested to learn more about them, you can actually access the recording on the iEcho platform, and we'll have the recording, slides, and even other resources that we have discussed during those sessions. So please feel free to go in and click into the previous sessions if you're interested. So thank you to everyone for coming on time. And I'm now going to hand the session over to Norman for any housekeeping and announcements before we start.
Thank you, Pui. Just the usual announcements or housekeeping rules that we have for ECHO. For folks who have joined us from the beginning, I'm sure this is not new, but for those who are new to our training sessions, we first encourage you to change your name on Zoom to your name, your area of expertise and country, as you can see some of us here. We encourage you to drop all your questions or even reflections in the chat box as our sessions go along. We also encourage you to turn on your video and to use the mute button if you're not speaking. As mentioned, that the session today will be recorded and will be uploaded on the iEcho platform. We also have translated captions enabled. So for individuals whose primary language isn't English, you can toggle enable the translated captions in the captions and translation function down below, and you can choose which language that you'd like to have the captions in. Very brief announcements, Malaysian clinicians, for you to receive your CPD points, will submit your attendance to MMA, but please complete the CPD form that will send to you in the chat box. For clinicians from Japan, you can submit the certificates of attendance to JSAR when you receive the certificate from us. Australian participants, we will also submit your name and your place of practice to ASHM for your CPD points. That would be all for now. Over to you, Pui Lee.
Thanks so much, Norman. So we're going to go into our didactic session. And so with that, I would like to introduce Professor Andrea Mayer. So Professor Andrea Mayer is a professor in gerontology and fellow of the Royal Australasian College of Physicians. She became a full professor at Universiteit Amsterdam, sorry if I'm pronouncing it wrong, in 2013 and headed geriatrics there until 2016. She later held leadership roles at the Royal Melbourne Hospital and University of Melbourne, Australia. Currently, she's director at the National University of Singapore's Centre for Healthy Longevity. Her research focuses on unraveling the mechanisms of aging and age-related diseases to bring diagnostics and interventions to optimize health into clinical practice. So Professor Mayer has published over 430 articles spearheading significant contributions of her highly acclaimed, innovative, global multidisciplinary age research group. She also founded Singapore's first evidence-based longevity clinic. She advises global organizations like WHO and leads initiatives promoting healthy aging worldwide. And today, we're fortunate to have her speaking to us on healthy longevity, prevention of comorbid disease to start off this new year. So welcome, Professor Andrea.
Thank you, Professor Pauline Wong. Thank you so much for joining this meeting. And I must say thank you. Professor Rina Rajasuria was here in Singapore, and I think visiting us. That's the reason why I'm here now. So thank you so much. Really linking this great research you are doing, HIV, to something which is called aging. And you might see or already know that there's lots of overlap of accelerated aging. There might be in HIV and in the past with AIDS. So hopefully you can learn something. I am an internal medicine specialist and geriatrician. I will focus really on precision medicine and will share my slides now. And hopefully that will lead to lots of collaborations in the end, but especially now, lots of conversations and discussions. Yes, okay. I think you see my slides. So I called this presentation matchmaking because everything is about precision medicine at this moment in time in all the fields in medicine, and we coined the term precision geromedicine. If you haven't heard of it, don't worry. It's really new. We called it healthy longevity medicine until a couple of months ago, and we will still use that word healthy longevity medicine. But we got lots of feedback that healthy longevity medicine, what is that? Is that really attractive? And it's not a Greek word. And so we said gero is aging, and we said precision medicine, precision geromedicine, instead of evidence-based healthy longevity medicine. So thanks for joining. I will talk about the roadmap towards precision geromedicine because it's not yet implemented. And we really reach out to lots of specialties like endocrinologists, cardiologists, surgeons, anesthesiologist and infectiologist to really see, okay, how could we work together to bring really preventative actions into the different disciplines which are already existing, while enabling us to create a new specialty, which is precision geromedicine. There are three important key terms which are relevant. It's geroscience, it's gerodiagnostics, and gerotherapeutics. Geroscience is the really understanding of the biological backgrounds of the aging process, so the biology of aging, and how can we bring that really fundamental knowledge of why we age. Everybody is aging. That's a negative thing at the moment, at this moment in time, in this room. How can we bring that knowledge into something we call precision geromedicine, into diagnostics and into therapeutics? So in other words, how can we bring and translate knowledge from fruit flies or from C. elegans or from mice or from monkeys into the human space? Because colleagues of mine always joke, we fixed actually the aging process in many organisms. For example, mice or C. elegans, it's quite easy to extend their lifespan, but also their health span by 30 to 50%. So can we do that also in humans? And then there's an ethical question, do we want it? So that geroscience, gerodiagnostics is really measuring the biological age of individuals. As you know, we have the biological age and the chronological age. So the chronological age should be obvious to you. That's your age you have at the moment based on when you were born. But the biological age is really dependent on the pace of aging. So think about people who are aging faster and slower. They have a higher or lower biological age at that moment in time. So now we can measure the biological age and we can compare that to the chronological age. And we measure that with lots of biomarkers of aging. I will have a couple of slides about that, how we do that. And I think it's ready for implementation into clinical practice. So there might be an overlap in our practices. I think it's quite unethical sometimes to just diagnose if you don't have therapeutics. So that's the reason why we need gerotherapeutics. So how do we lower the biological age? That's our primary KPI and our outcome. And how do we establish actually pathways that we not only diagnose, but also intervene with, of course, the KPI of lowering the biological age, but in the end, that should also be cost effective. And we are not there yet at this stage that we have that answer, that we have an avoidance and a preventative action of age-related diseases, but that's something to come because we are just an emerging field. So why did I invite, no, Rina actually invited herself, and we greatly appreciated that to come to Singapore, because we know, and just give you one slide of a very nice study I found, that individuals who do not have HIV in the beginning and develop the infectious disease, have HIV, that they really have an accelerated aging process measured with biological markers, for example, epigenetics, also changes in the microbiome on the clinical side, and that we see molecular footprints in HIV positive persons compared to controls which do not have HIV. By the way, it's the same for people with diabetes, have a higher accelerated aging, people with early dementia. We already see the footprint, and that's what we want to avoid. If you look at the very high level, what we want to achieve in Singapore, but also in Asia and worldwide, this is a little bit the pipeline. So we have 20 years of experience now in geroscience, where we understand the aging process. That's what we are really now, since 5 to 10 years, bringing into human studies. We call that healthy longevity medicine research. Now it's called geromedicine research. But really seeing what the validity is of gerodiagnostics and gerotherapeutics. We do randomized controlled trials now. That's being implemented into clinical practice, implementation science, and health longevity medicine clinics. A year ago, we founded the first publicly funded health longevity medicine clinics in the world, which is in Singapore in the Alexandra Hospital. And that has to lead, because everybody is not escaping aging at this moment in time. So 100% is aging, which means we need a public health approach. So we need to go globally in an evidence-based approach. And that's the reason why we already have the discussions with the WHO, United Nations, of how do we tackle aging. If we are going at a level deeper, what is the Singapore approach? This will be published very soon. We have the understanding why we age. We call that in our world the hallmarks of aging. We have at the moment 12 hallmarks of aging, but these are increasing hugely. So, and the geroscience is really based on animal models, is being translated now. And what we do is bringing it into precision geromedicine research. And here you see diagnostics and therapeutics in the circle, and that's very important. While we are measuring, we want to intervene, and we want to measure again to see if our therapeutics have effect, of course, as we normally do in clinical practice. And we see on the left-hand side biomarkers of aging, which serve gerodiagnostics, and we really segment them in digital, clinical, and biological ones, and I will go further on it in a couple of slides later. You might be able to use genome, and recently we defined gerogenes and gerosuppressors. Think about oncology, where we have oncogenes and suppressors. Have the same association now. Genes who are facilitating more the aging process, so not so good, but delaying the aging process, and that's the ones you would like to activate. And in terms of therapeutics, we have 4 very big groups. We really have to look at the environment. Where do we live? What kind of exposures do we have? It can be light, it can be toxic, it can be the social environment we are. Then the very big group of lifestyle, including sleep and what we eat and how much we behave, physically, how much we move. So a huge bucket. It's 10 hours, I think, of presentation in itself. We have supplements where we really now know what kind of molecules are inside, and we are giving them specifically, which are not under the regulations of drugs, but are very potent molecules where we can maybe stop, delay, or interfere with the aging process. And then we have drugs, as every specialty, at least in internal medicine, and we very often now repurpose the drugs. Think about ACE inhibitors, rapamycin, beta blockers, etc., but we know that there might be pleiotropic effects. So not only serving a certain disease, the indication where it was given for, but we can also reuse it to have a pleiotropic effect. And one of the most studies that, for example, if we have that, and we are not done with research, absolutely not. I think we are in the infancy. We have to validate that in clinical practice. Then we have to give it to the general public, into healthcare professionals. We have to educate them what it is, what the biological age is, and that will then serve precision geromedicine clinics. And as I said, we have one, but there are many out there which are private at this moment in time, and we just have to shift the ratio to have many more publicly funded hospitals to do this. And that will lead into developing clinical practice guidelines, which we are quite advancing now. And that will lead, at least in Singapore, in the Healthy SG journey. Healthy SG is a program where the government, which was launched last year, that every Singaporean is enrolled with one physician. The physicians are being educated, upskilled, and we also want to do that with the health longevity journey with precision geromedicine. And that physician is really responsible to also develop the preventative plans with lifestyle interventions for each individual and checking in. And we really want to bring in an early phase that precision geromedicine approach into it first. As I said, everybody is aging, and then hopefully we will optimize the health and the health span of Singaporean. Why we target the entire population in principle in geromedicine, except of the ones who are terminally sick, or have very cognitive impairments where we cannot tackle the aging process, or the effects might be low. We do not touch children yet, because there's development and there's aging, so we do not know. So individuals, dependent on the country, 18 plus or 21 plus, are welcome in health longevity medicine clinics, independent of having a disease or not. So that's very important. Of all of them, we want to optimize the health. So this is the NUS Academy. We are really dealing with the human part of the process of the research. When I started and wrote the business plan for launching a health longevity medicine clinic, I got the question, Andrea, who is going to come to the longevity clinic? And I said, that's easy. And the question was from the CEO of the hospital where we wanted to start. So that's easy. Like, everybody who's interested in not becoming sick and interested in health. So why do you ask this? I didn't say at that moment it's stupid, but hey, come on, it's obvious. But in the end, I thought about it and I thought, is it really true that, because it's my perception that it's logical, but do people really think and perceive health that it is to optimize, that they don't want to fall sick? And if you're looking at the knowledge at the moment, it's very, very normal to go to the GP if you have symptoms and to diagnose something, to get a pill, and then lots of chronic diseases occur. So to answer these questions about the public perspective of lifespan, healthspan, and health longevity medicine, and the perception of health and what is health, we started with a consortium. First, we started in Singapore. We thought, okay, we will do a survey. And that really, while being very enthusiastic, led to a big consortium. In the consortium, we did surveys. It's all international now. And the first country who did the survey was in August, September this year, of last year now. And you see the first results of it. We wanted to know how many of the Singaporeans, an unbiased approach. We knocked on 20,000 doors of Singaporeans in HDB flats, and 2,000 open and did the survey. We wanted to know, do they know what lifespan is? Do they know what healthspan is? And are they interested in health longevity medicine? Here is 90% or nearly 90% know what lifespan is. General population, median age of 45 years. 41% knew what healthspan is, what very surprising, and had the good answer. So they said they know it, and they said it's the absence of chronic diseases, which is right, following the definition. And more than two-thirds of the population were interested to come to health longevity medicine clinics. And this was very surprising, because I thought maybe it's 10 or 20%, but not two-thirds of the population. And here you see a huge problem. Like, people understand that they don't want to be ill. They want to invest in themselves. We ask, do you also want financially in yourself? So would you pay for a health longevity medicine clinic? And half of them said, yes, absolutely. It's my, like I'm not sick conventionally, but I want to optimize. I also pay to go to the gym. Yes, of course, I would pay. So this is all in progress, but I think it's hugely exciting. If two-thirds of the population wants to come to a longevity clinic, at least in Singapore, the numbers I just got from Java, Indonesia, are a little bit lower for especially rural Java, like 20 30%, but still I would say high. We need physicians, we need an ecosystem, and we not only need an ecosystem of health longevity medicine physicians, but we need an ecosystem of all physicians, because in the end, everybody who is clinically active, and I'm very delighted to hear that there's such a multidisciplinary team here at the moment, we need to work together to see how we can stop or antagonize the aging process. So the first thing is we came together 3 years ago. We founded the Health Longevity Medicine Society, which is the peak organization for physicians, for clinicians, healthcare providers. And we defined health longevity medicine, which is now precision geromedicine, as optimizing health and health spans by targeting aging processes across the lifespan. So very broad. We also then frameworks. So how can you actually bring it into the first 3 hospitals who were all launched last year, which is the Alexandra Hospital here, the Sheba in Israel, and the Mayo Clinic in the US. We formed a working group and we built a sort of framework how to build clinics. So if hospitals want to jump into the cold water, also financially a little bit, and to say, okay, we want to give diagnostics, we want to give intervention, we've gone to measure outcomes, especially also in the research phase. We wrote down how to do that. So who should be included? How does a multidisciplinary team look like? What kind of diagnostics should we do? What kind of interventions? And how can we really make sure that the outcomes are meaningful, that people feel better for themselves, but also financially, we have cost effectiveness in the end. So that's very exciting. We don't have results yet, but they will come soon from the Singapore side. The real milestone in our field was in October last year. We worked hugely hard with departments of health to introduce the concept, because healthy longevity medicine, precision geromedicine does not exist yet on paper, or did not exist yet on paper. We wanted to have, as infectious diseases has it, as endocrinology has, as every medical specialty, we wanted to be acknowledged. So we worked in the past year together with the Department of Health of Abu Dhabi to set standards of what is healthy longevity medicine. So we wrote it up and it was signed off in October by the Department of Abu Dhabi. Abu Dhabi is very straightforward. They want to have implemented preventative measures, and they just jumped as the first department into this relationship with the Health Longevity Medicine Society. And in November, the first clinic was in Abu Dhabi. That was the Institute for Healthier Living, was accredited. And now there is lots of discussions with lots of Asian countries if they also could actually certify it. So there's a milestone, and then now it's moving hugely along, and we can build, which is great. What do we build? We are building a story, or we are building a story from cells to organs to then to including mental health, the well-being part, societal parts. But this is very important. We screen individuals. Most of the individuals we see are at the age of 40 to 60. They are very health conscious. We are screening them on biological, clinical, and digital things, and then we are matching. So that's the matchmaking with the adequate therapeutics. And here you see the same for pillars. How does it look like in clinical practice? And I will just show you a slide out of private clinical practice, because we can do much, much more at this moment in time. Here you see a client at the age of 58 nearly. You see the biological ages on the left corner side, blood ages. We have blood clocks. So if we are talking about clocks, we are measuring biomarkers of aging, which we express as years. So the delta of age between the biological and the chronological age, and that being measured by clocks. So we have blood clocks, we have epigenetic clocks, we have inflammation clocks, we have microbiome clocks. And you also see, so here you see that that client was older compared to their chronological age. And you also see that especially inflammation was very high. We scan the entire genome, and we see in the whole wide genome scan how that might influence, for example, the clinical phenotype, but also the clocks. And on the right-hand side, you see all the organs we are screening in terms of the aging process. So the genome came actually in quite late, because there are many people already have scanned their genome. 3% of their Singapore population did it already privately, and there are lots of countries who now do it on population level, for example in the Middle East. So that led to I think, an exciting progress that we wanted to see if gerogenes and geroprotectors could be formulated. That's what we did recently in a paper. And now we are matching really the genes, which can easily be measured, to the hallmarks of aging. Why does somebody age and what is the pace? And we are matching that with multi-omics approaches, which are not, I think, prime for clinical practice yet, but with clinical assessments and anamnesis to then bring it into precision medicine. Why is it all important? Why do we really have to scan everything we can do in the body, at least now? Because we don't have the right biomarkers yet for every organ system. This is because there is not only a difference in the pace of aging between each of us here in the room, but also within us. The pace of different organ system in us is different. My heart pace is different. Pace of aging is different from my brain age, from my muscle age, from my lung age. And that's what we actually analyze. So we do that already in clinical care, that we can say one organ is more age compared to the others, and the pathophysiology is also different. But we looked at the interdependency of the different organ systems. So we showed that there is an interdependency in the organ systems, that, for example, if somebody is a pulmonary ager, that person is very likely in the future to also have a cardiac decline, and then after a renal decline. But there is independency, that if somebody declines in cardiac function, not being diseased conventionally, but declining, is not likely to be a pulmonary ager. So we now have different ageotypes in different organ systems. So knowing all of that and bringing that into clinical practice, we have to make sure that we have ICD codes. Of course, we want to diagnose something, and that's the reason why we're working since a decade now with the WHO on defining what aging is. So vitality and intrinsic capacity came out of it. And now we are converting this concept of aging, where we understand the biology, to also how it's expressed. And you all see here, for example, locomotor function, cognitive, sensory, psychological. We transform these kind of things in conventionally healthy individuals into what is normal and what is abnormal aging. And we convert that into aging-related ICD codes. And that's being done by a consortium of the Cardiff University, and now going very well, that we have 50 working groups working on what is just normal, but maybe not good enough, because that's not optimal. In terms of interventions, what we do in clinical practice, and especially in randomized controlled trials, just a couple of slides before I close. My group is especially focused on that precision part of interventions. One of the very important molecules with lots of potential is alpha-ketoglutarate. Alpha-ketoglutarate can lower the biological age of the epigenome, very likely. So we have our genes, we have our epigenome, how much methylation sites, and then so which genes you are actually using, and very likely we can switch on and off genes by doing it, and that's very important. So we are really now including already our participants, our aging participants, which are all healthy, into randomized controlled trials based on the biological age, and we are measuring that with epigenetic clocks, which are now available, and we are using 4 different clocks and using the median out of it. And then we are only including the ones in terms of the precision, and the ones who are in terms of the epigenetic clocks older, and we try to revert that with molecules like alpha-ketoglutarate. We do the same for supplements like as nicotinamide mononucleotide with the aging process, NAD levels, which is very essential for mitochondrial function, go down with the aging process. So older individuals have lower. Very often then it's hyped in the media, okay, take NMN, take NMN, take NMN. That's not right, because we did a randomized controlled trial really showcasing that only 50% of the participants who got NMN actually respond to NMN, because they already have either good NAD levels or they don't need so high NAD levels. And what we do in these kind of precision geromedicine supplementation studies is really measuring NAD levels. We are giving NMN, and we are saying, okay, what is an optimal dose? And we also now do that with AI and machine learning to really customize, and for example, nicotinamide mononucleotide supplementation, but we are also going to do that with drugs and with other things to really pinpoint of what is needed for whom, when, during the aging process, just as an example. We also do lots of systematic reviews. I don't ask you, I don't have the time who's taking multivitamin mineral pills at this moment in time, but be careful. They might not work, at least not for you. We did an umbrella review of multivitamin and mineral supplementation because 60% of the Singaporeans take at least in regularly it, and 30 to 30% take regularly multivitamin and mineral pills. And we want to know really on a precision base who needs it really well. And what we found is just a summary here, which was recently submitted. Negative, positive, and neutral results. If we are looking at the positive ones, that individuals with neurological diseases and musculoskeletal hip fractures, for example, have benefit of it, but there's also lots of uncertainty. If you are diving into the studies, everyone who has malfunctioning of eating, so is malnourished, they benefit from it. So very often middle-aged individuals take it because it seems nice, the bottle seems nice, so why not? I think that's a bad indication. So if you're eating well, it's very likely that you don't need them. But we're now doing a study, a randomized control trial, including healthy individuals who are biologically older. So hopefully manipulating a little bit the biology. But what we do is really looking for evidence, fine-tuning it, and then doing a randomized control trial, and then if positive, implementing that into clinical practice. And that's what I share with many of other consortium partners around the globe, really shaping this new field, which should be evidence-based. To really make an impact is, I think, talking to you, talking to other specialists, and also talking to other societies. Like I already said that we are working with the WHO, but also the FDA, because if we are finding new drugs, they have to be implemented in the end. Medical council, consumer organizations is very important. And we found it really a framework between different societies like the Academy for Health and Lifespan Research, LBA, to work together to really bring it from healthcare professionals to investors to pharma, and in the end, hopefully to the consumer. So this is the same roadmap. Geroscience, gerodiagnostic, gerotherapeutics is very important. If you want to learn more, we are heavily invested into education. There are 2 QR codes to scan, happy to share. We have the second Health and Longevity intensive course for healthcare professionals in February, end of February. And then we have the Unlock Health and Longevity conference. So it's 4 days of conference, and then it's being closed by a public day. So if you want to learn more, we have a disease approach, but we also have an aging approach. And we will tackle the entire spectrum. Thank you so much.
Thank you so much, Prof. Andrea. That was really, really interesting. Yeah, that was a lot to take in, but I think it's probably the first time a lot of us are hearing about geromedicine, precision geromedicine. And I'd just like to open up the floor for questions. I'm just going to check the chat box. And whether there are any questions from the hub members as well. Yeah. If no one has a question yet, maybe I can start us off. Rose Nyaboki, you have your hand up. Feel free to unmute.
Yes. Good morning, good afternoon. This is Rose Nyaboke from Nairobi, Kenya. Thanks, Professor Andrea, for the good presentation. I've actually been following, and I'm an expert in HIV field, where we have quite a number, when we talk about HIV and aging, it's one of the hot topics that we have currently, considering children born to HIV, being initiated on antiretroviral treatment, the aging, the rising of non-communicable diseases. I don't know whether there are some other things probably she can be able to mention about, the HIV and aging, because I'm currently seeing a trend of, significant number of children having, comorbidities, and now they are growing. So what next? Thank you, and back to you.
That's a great question. I would love to be an expert on it, because I'm not even an expert. As I said, we do not touch children at the moment because we cannot disentangle what this development is versus what is aging. I think personally, from a biological perspective, aging starts with the first cell division, which means far before you were born. But how to do it and what kind of mechanisms are important. For example, think about senescence. Senescence is if a cell is stopping dividing. It had good parts and bad parts, and especially good parts in development. So we do not know. So if we always say that aging is a root cause for aging related diseases which occur at a certain age. How that actually translates during development, I looked at it today. I couldn't really find from an aging biological perspective look at it. However, I think then you have epidemiology next to biology. The prevalences of aging related diseases or I think syndromes are higher. But I think nobody, or I'm not the expert to then touch on HIV and when you should treat it, etc. But this is something to explore together because we have the biomarkers. We are now starting applying the biomarkers we apply for adults during development to actually to learn and what that means and to interpret. But far too far away from clinical implementation. This is really research. So sorry that I don't have the answer. I would love to have the answer.
Thank you so much, Rose, for your question, and Prof. Andrea for your response. Can I invite Jenny first, and then we'll follow with Han Young after questions.
Hi, my name is Jenny Hoy. I'm an infectious diseases physician from Australia, actually from Melbourne. My question is about the epigenetic clocks. And there is some discussion in the literature about are we ready to use epigenetic clocks clinically, or are they still really a research tool? And also there seems to be many different epigenetic clocks that are telling us different things. So I wondered whether we're really ready for prime time precision geriatric medicine treatment, or what is your response to the literature saying we're not ready?
Yeah, that's a great question because I have the answer. So or at least an answer of the Health and Longevity Medicine Society. So I'm leading the working group of the first guideline of should we use epigenetic clocks in clinical practice. So that's coming out end of this January. So the consensus of the stakeholders, which are very broad, say yes. And we are talking about looking at, of course, validity, how reproducible are they, what could we do, and whom should we apply it. So yes, and very importantly, because otherwise the question is coming, should we apply different clocks to different ethnicities? We are not there yet. Different ethnicities have different risk factors, and maybe that's even shown in epigenetic clocks. We just did studies here in Singapore, including Malay, Chinese, and Indians. And Chinese are the biologically, epigenetically the youngest, and Indian the oldest. If you're looking at the risk profile, if you're looking at the incidence of diseases and what it is, it matches also these clocks. And if you're looking at the CPG sites, it matches. So there's a debate of if we should sex-dependent epigenetic clocks. So which CPGs to use? That's the first thing. So I can release that guideline once it's released, a couple of weeks. Secondly, yes, you're right. We in our group have 28 different clocks in algorithm. So which one to use? And there's also then not only clocks but also measures of pace. What we do in terms of risk mitigation, we are using second and third generation clocks. For the ones who are not in the clock first generation clock is predicting chronological age. I I don't think that we should do that. Just ask. Second generation clocks is predicting mortality. That's already okay. It's especially for observational longitudinal studies, very nice. But for me, relevant are the third generation clocks, and that's the incidence of diseases, aging-related diseases. So also that in the guideline will be that the second and the third generation clocks are the better ones. And we are doing risk mitigation in clinical practice, I at least, and also in randomized controlled trials to use 4 different clocks and take the median, because they are differently in the algorithm. They are looking at different CPG sites. Steve Horvath, who has the Horvath clock, the founder, said, Andrea, you have to now think differently about epigenetics. You have to, you know, every lab value. We all know what HB is and the creatinine and all these markers. So, and you can interpret it. Think about, you have now CPG sites and interpret it the same. And I said, Steve, these are 940,000 we can measure at this moment in time. I only have 60 of my lab values. But I think this is where really machine learning and better understanding kicks in. So I think it's the early prime time, but the better understanding we do not have. It's like 10 years ago where we had no clue. We measured SNPs, but not the whole wide genome scan. We didn't do polymorphic risk scoring systems. So infancy, I use it, and it's very, very delightful to use and also see the reversal, because these are clocks which are changing over time if people do the intervention. So they are getting younger. It relatively works, at least in clinical practice of mine.
Thanks, Prof. Andrea. I think we'll take one last question with Han Yang, and maybe for the other questions in the chat box, I'll just get your help to reply them after, if that's okay. Thank you, Han Yang.
Right. Thank you, Pui and Prof. Andrea, for your very interesting sharing. I'm Han you can call me Han. I'm the counselor background, and I work a lot with the primary healthcare. So my quick questions is, I know precision medicine is very interesting and fascinating what you shared with us. It seems to be very applicable on the tertiary care level. And on the setting of Asia and also Africa countries, for example, primary healthcare, I just wonder, while that particular subspecialty being setting up at this point of time, is there any quick things that the primary healthcare can adopt in terms of what can be done in their own primary healthcare setting, dealing with their mass population of patient in terms of precision medicine? So that's a quick question.
Yeah, great question. So don't implement epigenetics at the moment. But what you should do is very often we do, or many at least do now, annual health screenings, or at least an annual glucose measure, or an annual blood pressure measurement, an annual weights if we can. I think the first thing we should do is not looking statically at one result we normally do, but tracking it over time. And tracking it over time, that we actually track it over 10 years. And there, family physicians are so important, and GPs, because they have that long history with them. So track it over time and see where it's tracking. That's the first thing. So make out of a person a story, and not just a snapshot, because in medical care we very often, because of time, these are snapshots. It's all okay, come back again. But we can learn from these subtle differences. That's the first thing. If there are subtle differences, that's the second thing. Think about that everything which is in a normal range might be leading towards a pathophysiological range, and try to push them to be optimal. So another thing we are doing in consortia now is, what is optimal? Why do we dichotomize our body and dichotomize our health? This is good and this is not good. But we know that if something is just normal, we already have a risk of having in 10 years diabetes, or having in 20 years a stroke. So how can we push normal to be optimal? And that's, I think, what GPs could do. And we in Singapore will will develop, which has to be ready in May, GP courses to bring the precision geromedicine into family medicine. And that, of course, should spread across everywhere, and very happy to collaborate. But it's this tiny difference with what you already have to reuse it. So all these blood clocks can be used. I showed you the analysis of the network of bodies. This is all based on the UK Biobank on normal GP data. So we can reuse it and interpret it differently and smarter.
That's really interesting. Thank you. I think we need to keep an eye out for those courses as well, and see if we can somehow join in on them to see how it works in primary care. Well, thank you so much, Prof. Andrea, for that really interesting talk and for all the engaging conversation as well. There are one or two questions in the chat box, which if I could get you to answer, you might have
doing
answered.
that now.
Thank you so much. And for now, what we will do is we will move on to the next section of our session. And normally what we do is we have a case presentation and have a discussion after. But today our format's going to be slightly different because we have invited Mr. Andrew Tan to come and speak to us today to share a little bit about growing older with HIV. And I'm just going to introduce Andrew before he starts. So Andrew Tan is a leader and community activist for people living with HIV. And this journey began with his own diagnosis in 1994 at the age of 34. At a time when treatment options were scarce and stigma was pervasive, Andrew faced significant challenges, including blatant discrimination, such as health officials advising his mother not to rent him a room due to his condition. Despite these obstacles, Andrew has transformed his personal struggles into a lifelong mission to support and empower others. In 2002, Andrew began volunteering, driven by his doctor's suggestion to channel his energy into helping others. Since then, he has become a beacon of hope for newly diagnosed individuals, offering support and counseling to help them navigate the complexities of living with HIV. His work has expanded far beyond Malaysia, with Andrew conducting training sessions on HIV treatment literacy across Asia, including Thailand, Bhutan, Nepal, Bangladesh, and Sri Lanka. As the president of the Kuala Lumpur AIDS Support Service Society class, Andrew has led numerous initiatives to improve adherence to treatment, combat stigma, and promote understanding. He also serves as the community representative on the Lancet HIV Commission on Aging and HIV, and as a member of the International Coalition of Older Persons Living with HIV. Through resilience, compassion, and leadership, Andrew continues to advance the conversation in living and aging with HIV, inspiring others to challenge stigma and embrace hope. So with that, I'm going to invite Andrew to introduce himself a little bit, and then we'll go into asking him a few questions.
Hi, everyone. My name is Andrew. Can everyone hear me properly?
Yeah.
Okay, great. My name is Andrew, and I was diagnosed in 1994 when there was not much information on HIV, and everything was what you heard on media, all the fear ads that you saw, and I think it was a time also when there wasn't much choices of medication. I started a year later, 1995. On AZT monotherapy. So over the years, I've gone through the gamut of medicines like stavudine, D40, didanosine, DDI, indinavir, quixaban, as well as the standards like efavirenz. And that was the days when they didn't have 600 milligrams, so you had to take 3 tablets. At one point, I was taking 20 tablets a day, and it cost me about 2,000 Malaysian ringgit a month for that medication. So those were the really tough times, and I'm glad that having celebrated my 30th year of survival, I like to say that it's all because of my physicians, my healthcare professionals, who have been taking care of me all this while and encouraging me. Thank you.
Thank you, Andrew. I was wondering whether you could share with us a little bit about your experience growing older with HIV, how things have changed, whether it's your experience in healthcare or your mindset.
It's very interesting when I listened to Prof. Andrea's presentation talking about the clocks. For me, we measure our journey of HIV slightly differently, as I have been presenting to many people over the years. I've actually structured it in stages, in phases, because the speed at which people move through these phases depends on the individual, depends on the background, depends on their personal strength as well. So my 9 stages that I've created, I identified, is basically diagnosis, post-diagnosis, follow-up, self-limitation, pre-heart, starting heart, handling side effects, rebuilding your self-image, and the future, or our future. And each person powers through it at different speeds, at different in a way, it's basically depends on how much of help they have in terms of guidance, as well as the way they view themselves in terms of the stigma discrimination that they get from outside, or even the simple thing of self-stigma, self-discrimination. It takes some time for acceptance after the diagnosis before you can actually start working with people to talk about treatment. I'm sure many of the physicians here have experienced that with their own patients as well. And then the key part of the light bulb moment for many patients is when they realize that I'm still alive. And that's when they start to take an interest in the future, what they can do, sort of restarting their life. Taking time to look at their own needs, their goals for the future and things like that. Because prior to the HIV diagnosis, a lot of people feel that they are young, they are invincible, basically nothing can hurt them. So a lot of risk may be taken at that point in time. The decisions of whether to use protection at condom, or even nowadays it's PrEP, depends on their own assessment of their risk. But what I realize is that we as patients should not only be survivors, we need to think about being ultimate thrivers. We need to thrive, and we for that it's very important to have hope, or at least provide the patients with a semblance of hope that they can achieve, which is not only just getting older, but also getting older in a happy and healthy state. Thank you.
Thanks, Andrew. I find it really interesting because I think normally for doctors we're always very categorical, right? So past a certain age and then you're considered old. That's how we like to categorize things. Whereas I think when I hear your perspective about growing older, everything is just such a continuum, and it's not really defined by age or a a certain thing, but really just like different stages and episodes and things that you're going through in the course of your lifespan or health span, as we're talking about this. I want to open up to some questions. So I'm just wondering whether anyone has any questions for you. Kenneth from Hong Kong. You can unmute yourself, Kenneth.
Hi, I'm Kenneth Chung from Hong Kong. I'm a physiotherapist who promote the active lifestyles amongst the people living with HIV. I'm interested to know your experience. So before and after your infections, do you have any lifestyles change? Or for example, if you get older, so what kind of lifestyle change or adjustment you method you use to fight against the aging? Or if you have some friends or some people living with the HIV have a very poor lifestyle or very physically inactive, so how can you encourage them to be more active? Thank you.
That's a very interesting question because I realize that I'm not the best example of living a healthy lifestyle. My life is generally very sedentary. My only exercises is chasing after my rescued cats at home when they create a mess. But the thing is that I suppose we don't really think about aging as we go through life and we keep doing the same things over and over again as we used to. The only time it really hit me was when my mother had a stroke and I was looking after her. I was packing her medications. And years later, when my doctors prescribed certain medicines to me, and when they mentioned the name of the medicine, suddenly it was a light bulb moment for me to realize that, oh, the medication is actually the same thing that my mom is taking, and it was quite interesting that that's when I realized that I'm actually aging, and moving on like my mom. But otherwise, the only other thing is that when you do what you normally do, and maybe your muscles or your joints are not responding the way that you expect them to, aches and pains and other things, those are the things that sort of remind you that you may need to take up some of the supplements. And then you know how it is in Asian countries that Western medicine is not really the first choice. They would opt for traditional therapies and things like that. So there is a lot of a push and pull in terms of recognizing the aging signs, as well as combining that with your blood test results and how much of an opportunity you take with that 15 minutes, 10 minutes with your doctor to ask them the questions about your results. So there are a lot of patients who are not confident enough to sit down there and actually speak with their physician on certain things. So all they want to hear from the doctor is that, okay, you're okay, your blood test looks fine, and they walk out of the room without knowing anything different from when they walked in. So there is a need for NGOs like ours to educate people so that when they go in to speak with the doctor, that 10 minutes, 15 minutes is very well used, and they ask all the right questions, they get empowered, and they walk out of the room taking charge of their own health, because the doctors cannot be with them 24/7. So we have to take on the responsibility of our self-care. Thank you. I hope that helps.
Thanks, Andrew. I think Jenny has a question as well.
Thanks, Andrew. I think what you just said at the end of that is actually what I was going to ask about, and that is the partnership between your doctor and yourself in preventative healthcare to try to prevent some of the effects of aging. And I was going to ask if you had friends that do not have HIV and whether you compare yourself to them and how the aging process is occurring. Because I know in Australia, men traditionally are not very good at going to their GP and having good preventative health care, and that's from the patient side, that's not from the GP side. Yet people with HIV have to go to their doctor on a regular basis to get their prescriptions. So they are getting preventative health care without actually realizing they are. They're being screened for different things. So I wondered whether you had actually compared yourself to any of your friends that do not have HIV and how each of you are traveling as far as aging goes.
Friends without HIV, I find that a lot of them are actually, they seem to be healthier because I'm on this chat group with all the old boys from my secondary school. And the way I see some of them post and share their lives, there are habits that quite a few of them have, which I would consider being very healthy. They wake up early, they have their breakfast. Some of them go for their morning walks, the hiking. They are still healthy enough to travel, so they take every opportunity to visit their grandchildren in Melbourne and things like that. And it's the goals that they have in life to live it fully. And many of them are actually very active. They take an interest even after some of them have retired. Some of them are still actively employed because they run their own businesses. But they ride bikes. So I get inspired by them because they live full life. Sometimes I feel a little bit jealous because the thing is that they have what I consider to be everything, health and a family life, etc. And compare that with the people within my support group, because there is a general, how do you describe it? A initial feeling of downness, so to speak. When you talk about being first diagnosed, that doesn't always go away. When they recover from the shock of the diagnosis and everything, and works through the side effects of medication, and then as they start to rebuild their life and everything, then we kind of hit them with the news that HIV actually ages your body about 10 years, right? And that's when they kind of feel like, oh, okay, now I've got this to look forward to. And knowing full well that happens in our body, we still feel very lucky to be alive because of the advancements of medication and everything. But the reality is that we need to create or get resources where people can access maybe aging measurements online, so that this could be can be measured even when they are not close to their healthcare facility. Because as people age and they retire, they might not spend as much time in the big cities or metropolitan areas because of the cost of living. They might move to rural areas. So that would distance themselves from the healthcare setting that they have been used to. And it might be further for them to travel. But at the same time, conversely, you actually have people aging, which requires more visits to different departments in the hospital. So that sort of doesn't connect that well. We need to solve that issue. Thank you very much.
Thanks, Andrew. I do have a question, but I'll let Sister Cheng Hong ask her question first.
Thank you, Billy. Andrew, thank you so much for the sharing. So I'm the one practice nurse in infectious disease in Singapore. So I'm just wondering from a healthcare consumer's point of view, do you find there's a soft line, drawn between or overtly nagging on lifestyle changes versus like providing the adequate amount of information on lifestyle changes? Because often I have to go through the long list of otherwise I have to give to my patient who has metabolic syndrome. I just can't help to think at the end of the session, am I being too naggy? So I just want to hear your point of view. Thank you.
Wow. Don't worry about being naggy. I think in the long run, the patients may not want to recognize that they're aging, but there is a need to alert them of what is going on in their body, because at the same time as we grow older, there is a level of denial as well, because they think they still feel fine. They can do their morning walks up and down their block, but the thing is that what happens is that there's a lot of processes that are slowing down within the body that might not be immediately visible. So that's where our regular checkup comes in, and the importance of their understanding that why they maybe need more blood tests, because as the physicians spot different issues, that's when they would decide on what medicines to add on to the range that you're really taking right now to manage certain conditions, like whether it's for the kidneys, for the heart, whether it's diabetic, whether it's for thyroid, etc., etc. Thank you.
Andrew, as I was hearing you respond to Jenny's question about comparing yourself to someone without HIV and the differences in terms of, I guess, their mindset and their health, I'm just wondering, thinking back, do you think that there is something healthcare providers can do or help address to kind of help bridge that gap that you see, or, in terms of health and what people are able to do?
Yeah, because I think for those of us who have been alive long enough to actually grow old, because at those earlier stages was that, will I even be alive? I think that was the question. Will I even survive this? And slowly it ended up, oh, I've survived 1 year. Oh, I've survived another year. Oh, it's been 5 years now. Now it's been 10 years. So volunteering with class has given me a different perspective, because I see people at different stages of their journey. And I think I realized how fortunate I am have the relationship that I have with my doctors, and I encourage all the people who join our support groups to do the same, to learn more when they join us for sessions, so that when they walk in, they are better informed, so that actually just what I always think about this whole question of treatment for HIV. It's like this huge jigsaw puzzle. You may have the best physicians, the best pharmacists, the best diagnostics, the best medication supply, everything, all these different pieces of the jigsaw puzzle, but it's never complete if you don't have that little piece that represents the best patients. That little piece can only come across with a little bit of effort from the patients themselves, to look at what they have available to them, appreciate it, and realize that, hey, you are also responsible for your own health. You're also responsible for taking the medication on time. Nobody's going to slap you on the wrist when you miss it. You have to set your alarm. You have to get into a group, chat group, where people text when they've taken the medicine. That's what we do in class. We have a chat group that we call the Yam Sing group. It's like cheers, right? So when we create the group, we tell them you don't have to say that you've taken your medicine. You don't have to post a picture of pills. What you could do is 2 beer jugs, 2 champagne glasses, or whatever, and you just click on that emoji and send it. And if anybody asks, you can say, "Oh, my friend's out drinking again," But that, for us, it's a signal that, hey, I've taken my medicine. So it's that kind of encouragement, and that also helps for us to realize that this group of people are taking the medicines on time. So it's creating that kind of, I wouldn't call it competitive, but it's more of an encouraging atmosphere within the support groups. So that's the kind of thing that we need to encourage more of, the take charge and of your own health kind of thing. Thank you.
Thanks, Andrew. I think, Norman, you have asked a few questions in the chat group. I'm just wondering if you want to just unmute yourself and share these questions.
Sure. Andrew, I think what you've shared is really precious. And I'm sure you and all of us here, we know that community-centeredness is what we always talk about in the HIV response. So my questions really revolve around that. How do you think people with similar experiences to yours could support each other, particularly in addressing the issue of aging? And perhaps if you have any specific example from your own lived experience that you've reaped the benefits of social support from your peers in addressing issues that you think are aging related.
In terms of in terms of my own journey itself, I will share something that what I did was actually in the early years of my diagnosis. I had goalposts. I remember that first year after my diagnosis, my brother had his first child, and she was a newborn baby. So I think my brother was also a bit worried that about how long I would survive with HIV. Um, and he brought her every weekend to visit us, and made sure that I took the opportunity to feed her, to burp her, and I think that gave me hope. That gave me the encouragement to say that I want to survive long enough to see her grow up. I want to see her go to school. And when she went to school, I moved my goalpost a little bit and said that I want to see her um, go to secondary school. I want to see her go to university. And fortunately, by some um alignment of the stars, when she graduated from Manchester University, it was the same year that IS had the conference in Paris. So I went a little bit early. I attended her graduation. And after that, I had to move my goalpost again. And I wanted her to find a nice guy, get married. And when she got married a couple of years ago, I moved my goalpost again to say that I now want to be a grand uncle, And so now I it's it's my own journey, my own goals that I connected to my niece, and I think that's one way of creating that kind of hope, which is not really a scientific approach, if you call it, but it's more of an emotional tethering of I must keep myself healthy. I must take care of myself so that I can see this happen. And with my partner, it's aging together, and he has been looking after me since my diagnosis, and caring for each other in an emergency, and especially as recently as last year, he basically took on a 4 month caregiver role when I had a serious back issue that ended in a major surgery, for my lumbar L3, L4. So facing our own mortality and actually growing older is very real as we I suppose the markers for many of us are attending the funerals of our grandparents, our parents, aunts and uncles, cousins, and that starts bringing things closer to home, and you sort of realize that you have to really make a concerted effort in taking care of yourself, and changes in lifestyle, changing your diet, things like that. So yeah, it's one of those sort of journey things that you look at. Thank you very much.
Thank you, Andrew. Thank you for sharing and being so honest and candid about your thought process and everything that you've been through in this journey. I have no further questions, but I just want to say a great big thank you for agreeing to come and share with us your perspective of growing older and living with HIV, and kind of putting things into context for us as well, with everything that we've been talking about, improving care for people living with HIV. And so hearing your story has been very encouraging and very helpful. And so I just want to say a great big thank you from all of us. Thank you.
I really thank everyone for patiently listening. But one thing I also realized is that part of the idea of growing older is also becoming a useful human being, because initially when it came to the diagnosis, there was always this self feeling that I'm a bad son, I did something wrong, I am a useless human being. There's a lot of things that goes through my mind. But having survived for 30 years now, I realized that not only do I have to take care of myself to avoid any burnout from my the volunteer work that I do, but at the same time, I need to give back to the community. I need to make sure that they not only observe and learn, and I share whatever I can with them, but also I hope to inspire them so that they can give back and pay it forward. So I always go by I call it the 5 E's: engage, educate, empower, enable, and encourage. And that ends up with the 6th E, which is effective. Thank you.
I think that's fantastic advice to end the session with. And you have definitely been very encouraging to a lot of people here in Malaysia with the work you've done. So thank you, Andrew. I'll hand over the session now to Norman for any last announcements before we wrap up. Thanks, Andrew.
Thank you so much. I hope after this session, I'm sure there's a lot of us, myself included, who has a lot of things to reflect upon after this session, and things perhaps that we can read up on in preparation for the next session. So the next session is on screening and management of cognitive impairment in people living with HIV. Professor Bruce Brew, who's based in Sydney, will be leading the didactic, and we'll have a case presenter who's based in Taiwan, who's going to share a case from their experience. Next is feedback. So as you know, the CBD points that we'll provide, including the certificate of attendance, is contingent upon your completion of the feedback form. So we really appreciate you providing any feedback or any comments or any reflections that you have about the session. Also, this feedback is anonymous, and the system will automatically generate the certificate for you. So feel free to be as candid and honest as you can. We would really love to know how we can do better. Next is that although we already have our case presenter for the next session, we are still looking for case presenters for the upcoming sessions. So if you think there is a case that we can discuss, or something that perhaps you find difficult in your own local context, do reach out to us. We are more than happy to talk to you about how you can share your experience and share the case, and we can discuss together as a group on how we can support you. I don't think there's any other announcements, so I'll pass it back to Puli.
I think there's no more passing. I think we'll be drawing the session to a close. So thank you everyone for attending today's session. Happy New Year, and look forward to seeing all of you in the next session.
Bye.
Bye.
Bye bye.
Bye, everyone.
Bye.